Good morning, dear consortium members of the projects involved in OBEClust, dear participants. It's my privilege to welcome you to the second webinar of OBEClust, European Cluster of Obesity Research Projects, Strengthening Understanding of Obesity as a Chronic Disease. I'm Serap Erdine, Professor of Cardiology, Istanbul University, Cerrahpaşa School of Medicine, President of Turkish Society of Hypertension and Atherosclerosis, former Vice President of the European Society of Hypertension, and consortium member and chair of Communication and Innovation Board of EPROB's European Union project. As we all know, obesity is a global health problem, reaching up to 1/3 of the population. Can we move the slide, please? And it's one of the key risk factors, according to WHO report 2022, for many non-communicable diseases. Overweight and obesity affect almost 60% of adults and nearly 1 in 3 children in the WHO European region. And recent estimates suggest that overweight and obesity is the fourth most common risk factor for non-communicable diseases in the region after high blood pressure, dietary risks, and tobacco. And it's also the leading risk factor for disability, causing 7% of total years lived with disability. And early studies from a number of countries in the region indicate that the prevalence of overweight and obesity and or mean body mass index, as we see in this figure, has increased in children and adolescents during the COVID-19 pandemic. Can we move? Here we see the rates of body mass index and a high prevalence of those with body mass index over 30%. Next, please. OBEClust, joining forces to prevent obesity. Despite progress in obesity treatment, prevention remains the best option to avoid associated comorbidities. The European Cluster of Obesity Research Projects, OBEClust, is a pan-European multidisciplinary network of obesity experts linked to 9 European Union-funded projects aiming to enhance the collective effect of obesity research in Europe with an emphasis on prevention. And here we see the projects in OBEClust: PAGRA, Shift to Health, BioStreams, CoDiet, EPROBS, Healthy Weight W8, OBELISK, Better for You, OBCT, and it is funded by the European Union. And in this webinar, Strengthening Understanding of Obesity as a Chronic Disease, our aim is to enhance shared understanding of obesity as a chronic, relapsing multifactorial disease and support evidence-based, respectful communication across research, policy, and practice. And the webinar will explore how improved knowledge and framing can reduce stigma, strengthen research relevance, and support system-level responses. And we have a lot of participants, and our target audience is not only the healthcare professionals, researchers, clinicians, but also the policymakers, data specialists, digital health researchers, and patient advocates. And we have a really good program in this webinar. Here we see the agenda and very distinguished speakers. So before starting, I would like to express my thanks on behalf of the OBEClust group to all the speakers and also to those, starting with Marie, Anili, and the dissemination group of OBEClust for their really efficient work in preparing this webinar. So I would like to start with the first speaker, to invite the first speaker, Mr. Ken Clare, to give his speech on lived experience, what respectful engagement looks like. Please.
Thanks everyone. I'd like to thank the organisers for inviting me to speak at this webinar. I'm sorry I can't be online in person, but I've recorded some of my thoughts. And I'm going to talk about the lived experience during a consultation, what respectful engagement looks like. These are my affiliations. I'm a past chair of the European Coalition of People Living with Obesity. I'm lead for patient and public involvement in the Obesity Institute at Leeds Beckett University. I'm a council member of the British Obesity and Metabolic Surgery Society, and I'm an executive director of the United Kingdom Coalition for People Living with Obesity. These are the declaration of interests. It's important to understand that for me and for many people, obesity is a lifelong journey and it's a family disease. And that's a picture of me as a child and a picture of my mum. From my very earliest memories of my mum, she was always worried about her weight, and she passed that worry onto me, and a constant really obsession from very early childhood about weight. And I was always a worry to the school doctor and then to primary care, and that continued into adult life. Many people living with obesity have had lots of negative experiences. Unfortunately, these aren't a one-off. They're usually on numerous occasions, and when you talk to people, you'll hear those stories. They can occur in a variety of healthcare settings, from primary care, secondary care, and even the dentist. The cumulative effect of all of this takes its toll on people, and some people never go back for help from healthcare professionals because of the experiences they've given. Many of the people that I work with who live with obesity have seen stigma, bias and shaming in healthcare professional settings. How can we improve this? Well, I think it's really important to me that first impressions count. And they say that in a lot of walks of life. I don't know if that translates well into all languages, but the first impression that a patient gets when they walk into a clinic is really important. They'll be worrying before they get into the clinic. Are there going to be chairs that I will fit in? Are there going to be chairs that will take my weight? Will the blood pressure cuff be able to take my weight? Will the toilets be able to take my weight? If you've not been in this setting before, these are the things that are going through a person's mind. Will there be enough chairs that fit them? Is all of that stuff equipment? Is that suitable? Have the reception staff been trained? So really the training and engagement needs to start before the clinical consultation. And many patients have been put off by the attitude of the reception staff in the past. What about the consultation? And many of you will do this, I know, and I feel the English expression is teaching grandma to suck eggs, but not everyone does, and I think it needs to be pointed out. Please greet the patient at the door and be very patient when you open the door and the patient's name has been called. I'm very slow when I walk, and many people living with obesity won't be able to be there straight away. It's appreciated if you can welcome a patient with a handshake, establish eye contact and a smile, ask them to sit down. Important thing for many people is, what is your preferred name? What would you like me to call you? My name's Kenneth, but nobody calls me that apart from my mother when she was in a cross with me on a Sunday. So I prefer to be called Ken, and that's a really important point. It helps people to feel comfortable. And all this might seem very simple, but you'd be amazed how many times patients tell me this doesn't happen. Quite a common thing is say to a patient, can you just pop or jump or hop onto the scale straight away as soon as they walk into the door, into the consultation? Never do that. And never, ever, ever, please, expect patients to be weighed in the waiting area or a public area outside the consultation. It's a very private thing. Now, you can hear about the Canadian 5A's approach from people far more qualified than me to talk about them. But as a healthcare professional, I should have mentioned I'm a nurse and I've worked as a bariatric nurse as well. This is very important, but this is about for patients how they might see the 5A's. And the number one is the most important in my mind, and that's being asked permission for everything that takes place in the consultation, because that is the thing that has often gone wrong in the past. And then when you're assessing patients, and being weighed is obviously for a lot of people the most sort of common thing that's going to happen. Asking permission, is it okay? Because it can be difficult emotionally. Some people find being weighed triggering for various emotions. Make sure that it's comfortable with the patient to do that. And, make sure that the scales you've got in your consultation room are of an adequate capacity for all patients. I like about the advise, never always give options, not directives. And that's difficult, I think, for some healthcare professionals, and I include myself, because we're used to telling patients what to do. But give them options and let the patient choose. And it's a well-known fact that people who choose an option for themselves in consultation with a clinician will do better. Agree. I mean, for me, try and be a partner, or as a dietitian friend of mine put it, try to be an ally, work alongside and come up with a joint plan. And assist and leave that patient with some resources and follow up. And it's not just a one-off. This is going to come back to. The conclusions for me, and these are really important, that the first word, it should be compassionate, that people should give personalised care. We're all different people living with obesity, and we've all got different reasons, different things that bring us to the consultation. This is what people want, and they don't want blame and shame. And I think so many of us have had it, and I have a lifetime experience of beating myself up for the problems I've got around my weight. So we don't need to add any more to that. Hope that patients leave a consultation feeling positive and with hope about the future. And most importantly, the first visit's very hard to a consultation, but the second visit is crucial. We want the patient to come back to this place where their problems are being taken seriously. They can get help and hope and an understanding of working towards a realisation that obesity is a chronic relapsing disease and it's not their fault. I'd like to thank you for listening to the consultation. It's been very simple, I know, and I'm away on holiday and I'm sorry that it wasn't more slick. But if any of you have follow-up questions for me, happy for the organisers to pass on my email address. So I'd like to thank you for your time. Thank you. Bye-bye.
Thanks to you, Mr. Kenklen. It was very interesting. And it's my pleasure to invite Professor Jan Eriksson for his presentation on obesity, a chronic health issue needing chronic attention. Professor Eriksson.
Thank you. Let's see if there are some slides coming. So I'm Jan Eriksson. I'm a professor of clinical diabetes and metabolism research at Uppsala University, Sweden, and I am the Swedish responsible person for the GRAS project based at Uppsala University, together with my colleague Maria Pereira. And my task is to say something about obesity as a chronic health condition that needs chronic attention, clinical work. And as we heard from Professor Serap, obesity is obviously a major global health problem with very high prevalence. A billion of adults in the world are affected by obesity, and of course even more also with overweight. And this is growing, in particular in developing countries. And we talk a lot about unhealthy obesity and clinical and preclinical obesity. There was a Lancet Commission publishing a paper in last year, trying to define what is a disorder, a disease, and what is not. And they argue that if you have organ complications, which are shown on the right here, like having problems with liver fat, with cancers that are increased in obesity, heart and vascular diseases, a lot of psychiatric conditions, and of course type 2 diabetes, which is a main interest of ours. Then you call it clinical obesity. And in Sweden, we have about 60% of the adult population who are overweight, BMI over 25, or obese with BMI 30 or more. And about 20% are actually obese. So it's a huge problem in our country as well as in most others. And the cost for society and for healthcare is close to 10% of all healthcare costs. So it's a huge economic burden also. And I would argue that obesity, that is of course about adiposity, accumulation of excess fat, and all excess fat is hazardous. And this has been shown in many studies, and this is from actually Uppsala University, an old study, only in men, but showing that even if you have overweight or obesity, you have an increased hazard ratio of developing type 2 diabetes, even if you do not have any other metabolic disturbances. In this case, it's shown insulin resistance, but it also goes for dyslipidemia and prediabetes and for blood pressure, etc. So obesity in itself is a hazard for coming diseases. This is another very famous study, the InterHeart, also rather old by now, but it was multinational, and they could show that for a myocardial infarction, abdominal obesity was the absolutely most important risk factor, and also together with diabetes, hypertension, and dyslipidemia. And there are many behavioral factors that also increase the risk. And in particular, as I said, the abdominal obesity, so these aberrant placing of energy depots that has happened with time, that is detrimental. And all these risk factors are actually modifiable, so they are key for interventions. Why is the adipose tissue dangerous? Well, too little adipose tissue is also a problem because of it could be malnutrition, anorexia, or severe other conditions. But with accumulating increase in BMI, you have a higher risk of mortality and morbidities. And I would argue that this is due to the adipose tissue serving as a very active endocrine and metabolic organ. It's not just the storage of fat, it's also secreting many factors that can contribute to cardiovascular risk and metabolic risks. So this includes inflammation, atherosclerosis, thrombosis, of course, hyperglycemia and diabetes, dyslipidemia, and high blood pressure. And there is also input from nerves and the brain into the adipose tissue and different hormones. And we talk very much about ectopic fat and the fat distribution that is unhealthy. And the more ectopic positions of the body fat, the more danger there is. So This is not really proven in any scientific studies, but subcutaneous tissue is, of course, beneficial. That is where we want to store the fat. More problems if it is in the abdominal region, and in particular if it's visceral abdominal fat, and also fat in the epicardium and intrahepatocellular fat in the liver. Those are very detrimental. Pancreatic fat is not so much known about. There is a condition where you have limited possibility to store fat in subcutaneous depots, lipodystrophy, and that is also a high risk to develop cardiovascular and other conditions. So pericardial fat, liver fat, intra-abdominal fat, perhaps also renal fat depots are high-risk conditions. We work a lot with the interaction between brain and peripheral tissues, and also neuroendocrine axis. In obesity, the hypothalamus and cortical areas and other also subcortical central areas are very much involved in appetite and reward regulation, leading to increased energy intake, which is a prerequisite for obesity development. And similar pathways can also act on different endocrine glands and the adipose tissue to promote type 2 diabetes. So we work very much with these organs and the interplay, also gut hormones, for a therapeutic purpose. They are of high interest these days. And I would like to just highlight that energy balance, that is what determines the degree of obesity. There is no way to change a diet without reducing calorie intake if you want to lose weight. So there is a positive energy balance when you develop obesity, more energy intake than energy expenditure. And what happens then if you intervene and reduce energy intake with a drug or by just changing dietary intake? The body will compensate and reduce its energy expenditure to maintain its set point. And what you have to do then with the treatments, that is to keep energy expenditure up together with reducing energy intake. Then you can lose body fat. So this is what therapists must do, regardless of if it's a lifestyle change or a pharmacological or surgical intervention. One example that we studied that was to combine a GLP-1 receptor agonist that reduces food intake together with an SGLT2 inhibitor that actually increases energy expenditure by just excreting it into the urine as glucose. So this could be one way to have combinations of therapies. Low energy diet is of course the first line strategy for weight loss. And it can actually, if you do it in a very tough way, on a pulver diet with half the daily calorie intake, lead to prevention or remission of type 2 diabetes, shown in the direct trial, for instance, in UK. It reduces liver fat content and improves other risk factors like blood pressure and lipids. And it's, of course, safe. So that's a big benefit with a dietary approach. But this has to be chronic, as the title indicates, because of this compensatory reduction in cellular energy expenditure. And the commitment to long-term diets, that is very difficult. So losing weight is easy, but maintenance is the big challenge. With surgery, in mainly morbid obesity, you can achieve also remission of type 2 diabetes or very effective prevention of type 2 diabetes. And it gives a sustainable weight loss longer than what diet does typically, and improves also the cardiovascular and metabolic risk factors. Also has been shown to improve quality of life, but there are adverse effects, of course, surgical related complications, dumping syndrome, and sometimes hypoglycemia, but this could also be actually maybe beneficial and occur without symptoms, just a general lowering of blood sugar, which can be beneficial to diabetic patients. So what happens if you stop an intervention? This is an example from semaglutide. I will not talk anything more about drugs. With this GLP-1 receptor agonist, you can lose a lot of weight. If you take it away, this gray line, you will increase body weight and maybe not go back to the initial starting weight, but nearly with time. So you need to have this continuous treatment to have continuous efficacy, and that is, I think, general for most weight loss drugs. This is this direct trial from UK with the lifestyle management program. And the green lines there show the intervention groups and what happens with long-term follow-up. So they regain weight, and they also have a relapse into type 2 diabetes. So initial remission in about 60%, but after 5 years follow-up, it's most of these people have actually relapsed into type 2 diabetes. So it's difficult to sustain the efficacy, and that is a key challenge for our OBEClust programs to have a long-term sustained efficacy. This is one example which we are working from when we plan our intervention pilot studies in GRAS in Sweden, and that is to have a multimodal approach for lifestyle change. Our colleague who we collaborate with in this program, she's based in Skåne in southern Sweden. They went to a socially deprived area and with many immigrant population, and they had a very broad lifestyle program and involving workplaces and the society, the municipality, and the non-profit organizations like sports organizations and cooking education classes, etc. And they managed to break barriers and make these participants motivated and long-term increase physical activity and change their diet and live more healthy. And they actually achieved long-term weight loss, improved glucose regulation, less diabetes, and also, in fact, improved mental health. So this was very successful, and this is what we hope to do in our randomized control pilot trials in a larger scale. So in conclusion, of course, obesity is a serious chronic disorder. There's a huge individual and societal burden due to the complications. I would argue that that is the main problem of obesity, and that is when we also call it, according to the Lancet Commission, clinical obesity. And the interventions must aim for long-term efficacy. Short-term efficacy is easy, but the maintenance is the big challenge. And we're working, I think, in most of the OBEClust programs on multimodal approaches to this long-term effect on body weight and other cardiometabolic risk factors. Working with co-creation, involving participants and society, different organizations and educational activities. And in clinical obesity, we also need to think about all the possible interventions, not only diet, exercise, but also medication, and for some people also surgery. So I thank our collaborators in Sweden, in particular Maria Pereira, who works very much in the PAGRA project, and our funders. Thanks.
Thank you very much, Professor Eriksson, for your very nice presentation. Thank you. Now it is my pleasure to invite Professor Fernando Fernandez Aranda for his presentation, Beyond Weight, Global Insights into Psychosocial and Cultural Drivers of Obesity and Related Eating Disorders. Fernando is an expert in eating disorders, and it has been a great pleasure for myself indeed to work together with Fernando, both in Hyperchild Coast project and now in APROBS project. Fernando, please.
Thank you very much, Serap and organizers, for inviting me to give this talk. I would like basically to address the topic of eating disorders and obesity, some overlaps that we may have, and this is going to be a part also of the interest we have in EPROOF's project. I'm full professor at the University of Barcelona, and I'm director of Eating Disorders Unit. Can I have the next, please? I don't know if I can do it. Conflict of interest, basically some grants we receive, national and internationally. So the European project that is being umbrella of the work we are conducting now is the EPROOFs. The coordinator, as you know, is Professor Manuel Tena. Next, please. Yes, where we are participating 13 different sites. Next, please. The leading organization is Cyber, where we have four groups involved. Along the next 5 years, we are working on that, although we have started 2.5, almost 3 years ago. So next, please. Yeah, oh, sorry for that. Yeah. Okay, basically, we are interested in analyzing obesity, overweight, and eating disorders over the lifespan, the interaction that they may have, the impact of different factors, environmental risk factors, not only currently, but also factors in preconceptional or gestational period, also in early child age. Next, please. Yes. We have different challenges that we are going to discuss in my presentation. Next, please. Next. Sorry for that. I thought it was not this type of animation. So basically, the work we are conducting might be summarized in this paper. Is open access, and you can look at that, where actually different groups are also involved from EPROOFs, basically trying to look at the share and differential factors between obesity and eating disorders, what type of well-being factors, quality of life, but also mental health status are impacting also patients, participants who are living with obesity, and what type of consequence this may have. Next, please. Maybe I'm going to skip that. So basically, Jan also has introduced the impact over the years that obesity is having among different countries, as you have seen and read it in this Lancet presentation and also Lancet publication. Next, please. Also in EPROOFs, we were analyzing that, and we wanted to look at population data, how much and how strong is the interaction between obesity and social economical factors. In that case, we have analyzed Catalonian. As you can see, it was a direct association between low social economical class and obesity, 3 times higher than in other areas from Catalonian, and this we could replicate too in other areas. Interesting finding that we have found also in other countries, but also that they may have also political and policymakers consequences. Next, please. When we are looking at the interaction between obesity and eating disorders over the lifespan, it could happen as shown in this diagram. So obesity might be primary if we think in childhood obesity, and later appears the onset of eating disorders if we are thinking in children and adolescents who develop an eating disorders later on. We may have also the B condition where the eating disorder begins first, and then later they develop obesity. For instance, in cases who started with bulimia or binge eating disorders, later in life they are going to also have a comorbid obesity condition. And it could happen also looking at the clinical data, conditions C and D, actually, that they are going to be presented in a comorbid fashion. Next, please. Nope. Previous one, please. Yeah. So we are really interested in looking at individual factors, genetic, metabolic signs, neural circuitry, as also Jan has mentioned, looking at the hippocampus and different areas, but also at clinical phenotypes and behaviors. Next, please. When we are seeing genetic factors and genetic vulnerabilities, and we have recently published in a collaborative study published in Nature. Actually, we wanted to look at the not only the shared genetic vulnerabilities between eating disorders and other psychiatric disorders. In total were 14 mental disorders, but we wanted to look at transdiagnostic factors, not related to a specific diagnostic criteria, but looking more from transdiagnostic perspective. We were able to identify 5 factors and then actually also an important positive genetic correlations among different disorders. Next, please. Also, when we were considering obesity, cardiometabolic disorders, diabetes mellitus, and we were comparing with eating disorders, we were able to find out a negative genetic correlation between eating disorders, in that case anorexia nervosa, and obesity and other metabolic disorders, whereas as expected, it was a positive genetic correlation between anorexia nervosa and other mental disorders, namely anxiety, depression, but also schizophrenia and OCD. Next, please. Also, we have shown these shared commonalities regarding vulnerabilities in a previous paper a long time ago between obesity and extreme underweight conditions, in that case anorexia, where the similar locus was deleted or duplicated depending on the expression they had, clinical expression, in that case obesity or extreme underweight. Next, please. But not only genetics, next please, sorry. Not only genetics, but also cognitive factors might be also shared, and we are paying attention to that. Many groups we are working on that too. And then actually, basically we are analyzing executive functions and the potential impact that may have in therapy outcome. Next, please. Previous one, sorry for that. Yes, when we are looking also at extreme weight conditions, in that case from anorexia to obesity, we can also see some parallels regarding specific executive functions, and then actually we can see also on decision-making some shared commonalities, difficulties for decision-making, and also cognitive impairment, but also some differences, for instance, when we look at impulsivity, whereas in some cases there is more compulsivity, whereas in patients who are living with obesity might be the case that some groups may have also higher impulsivity. Yeah, next, please. No. Yep. And actually, this impulsivity is more accentuated when we are looking patients with obesity, additional comorbid eating disorders, namely bulimia or binge eating disorders, that they may have, again, so higher impulsivity than healthy controls, and also a specific higher activation in insula functions might be also expressed and might be also hyperactivated. Next, please. Also, recently we have looked at, in collaboration with some colleagues from Italy, from Padova, we were looking at the association between morphological differences, in hypothalamic subregions with hormonal aspects, again in extreme weight conditions, has been published at Translational Psychiatry. And actually we were also again interested to look at anorexia, at patients who have an obesity with a comorbid eating disorders, in that case, again, bulimia and binge eating disorders, but also we were interested in obesity, patients with obesity without an eating disorder. Next, please. We were able to find volumetric alterations in hypothalamus, also associated to specifically patients who were living with obesity, especially with an eating disorder, and also association with duration of the disorder. Next, please. When we are looking at therapy outcome, what type of impact may have also cognition, we were able to analyze that in one of the largest randomized control trials with Mediterranean diet. You may know that Predimed Plus with over 6,000 participants studied over the period of 6 years. Actually, we were focusing more in the 3 years follow-up. We were able to demonstrate that those cases who reduced body mass index and reduced weight over that period from where they were using Mediterranean diet, they were also having an improvement in cognition and specifically in memory, but also in executive functions. Whereas those who increased weight, they had more cognitive impairment. Next, please. When looking at, again, so therapy response, then focusing more in eating disorders with obesity, we have shown in almost 1,000 cases that actually those cases who had a previous or current obesity, they have poor therapy outcome, more relapses, and poor therapy outcome, short and middle term. Next, please. For those who are interested, we will recommend to look at this Prime publication, Nature Prime, where we were paying attention to binge eating disorders and also focusing on the impact on brain metabolic functions, but also clinical functions. Next, please. Nope. Previous one. Yeah. We are not only interested in individual factors, individual vulnerabilities, but also environmental factors. As we have seen in the social cultural factors, we are interested in food security, intake of high ultra-processed food, and also food addiction, how may impact also in participants who are having obesity, not only as a triggering, but also as a maintaining factor, and again, also on social economical factors and public policies. Next, please. As we have published in British Medical Journal, together with Ashley Gerhardt from Yale University, again, so it's very important also to pay attention, to do a lot of research on high ultra-processed food and the mechanisms underlying these ingredients and how far it also may impact in food addiction and also how it's impacting in therapy outcome and therapy response. Next, please. So take-home message might be eating disorders and obesity, sure, neurobiological and cognitive and environmental vulnerabilities, depending on the type and subtypes, the presence of lifetime obesity in patients with eating disorders, namely bulimia and binge eating disorders, is common. Both conditions comorbidly are associated with increased eating disorder severity, as we have seen, more cognitive impairment, but also more dysfunctional personality traits, and also the presence of lifetime obesity in eating disorders is associated again with poor treatment outcome. So it's particularly important that we pay attention to also a specific factor related to eating disorders, mental health conditions, well-being, in order to have a more broader perspective what's going on with participants and patients who are living with obesity. Next, please. Thank you very much, everyone.
Thank you very much, Fernando, for your excellent presentation. Before we move to the next presentation, we have one question from Marina Kosutana, a project advisor of HADEA, also our advisor. First, I would like to ask the question to Professor Eriksson and then take your comments, Fernando. The question is, new anti-diabetic medications are associated with clinically significant weight loss, even in the absence of dietary or lifestyle modification. If patients continue to consume unhealthy diets and maintain sedentary behaviors while experience weight reduction, what are the potential long-term consequences for metabolic, cardiovascular, and overall health? Professor Eriksson, please, could you comment? And then Fernando.
Yes, I think one should see these agents as support to do a lifestyle change. If you take a GLP-1 receptor agonist or a GLP-1 plus GIP, what is called tirzepatide, then you eat less, and if that doesn't happen, you will not lose weight. So it is a way to support the lifestyle change, and this needs to be continuous. So right now, we believe that you need to have the drugs on board. What I think we should study more, that is to reduce the doses to a lower maintenance dose and see if that can actually work long term. Because as you know, there are also potential side effects, and this has been much on the table during recent months. So there's still long-term data to wait for.
Thank you, Professor Eriksson. Fernando, would you like to make a comment, additional?
Yeah, maybe not directly to that question, but of course the comorbid condition between obesity, eating disorders, and diabetes is also something that is happening. So what we have analyzed, when we have analyzed obesity and diabetes together, so actually it had a lot of impact on cognition and of course on the brain, and those cases who were less adherence to, they have shown less adherence to the treatment. Also, they have poor cognitive impairment. So clearly something that we may need to pay attention to. With regard to eating disorders, the condition of diabetes is something that is there too, especially in bulimia, binge eating disorders, as you know. So usually they are using insulin as a way to compensate the effects, in the case of eating disorders, the effects of food intake. And this is something that, is having a poor impact in therapy outcome. When we have analyzed patients with eating disorders and diabetes, they have, unfortunately, the poor therapy outcome.
And also, as Professor Eriksson has mentioned, due to the side effect profile, once these drugs are stopped, then immediately weight gain comes back. So I think a reinforcement of the weight reduction and the long term, on the long term, re-emphasizing the dietary behaviors and quitting sedentary behaviors is much more important, not just leaning on the drugs themselves.
Yeah, actually, when we were looking to what factors have an impact in the weight reduction long term, also in Predimed, we have seen that different factors, as you have mentioned, lifestyle, but also impulsivity and also food addiction. So the need to have some food intake in front of stress and stressful conditions and how to cope with, it was an important factor influencing negatively the outcome. Yeah.
And
Thank
to
you.
Serap's comment on maintaining lifestyle changes, not only diet, but also exercise. I think that is very important with these drugs, because it has been a lot of fuss now around losing muscle mass when you take semaglutide, for instance. And there are actually companies now who try to develop activin inhibitors and so on that would build muscle mass per se, and that has not been shown to have any health benefits really. But what is very important and shown to be beneficial, that is to keep on exercising. Then you will not lose so much muscle mass during these therapies. Keep exercising and take your semaglutide or tirzepatide or whatever.
Thank you very much. And now we can move to the next presentation by Dr. Bianca Fuchs-Neuhold on enhanced nutritional health literacy to minimize obesity risks in shift values. She represents Shift 2 Health Project from University of Applied Sciences, FH Joanna. Please, Bianca.
Thank you, and a hearty welcome also from my side. My name is Bianca, and I'm a public health scientist and a senior lecturer and based in Austria at the FH Joanneum University of Applied Sciences. And Shift to Health is a EU project coordinated by the University of Vienna under the lead of Professor Karl-Heinz Wagner, cooperating with many partners, 14, yeah. And today I will share some special insights from the Shift to Health project, focusing on nutritional health literacy and how it can contribute to minimize obesity risks in shift workers. This is the next slide. First, just to give you a sense of the scale of the problem, around 80% of employees in the European Union worked shifts in 2023. So we are not talking about a small or a marginal group, but about millions of workers in the EU across essential sectors such as healthcare, industry, transport, and services. So second, there is a strong evidence. Please don't skip the slides. Thank you, Marie. So second, there is strong and consistent evidence linking shift work, especially rotating night shifts, to higher BMI and increased obesity risks. And this brings me to the aim of Shift to Health, shown on the map on the right-hand side, with our partners from 7 European countries, allowing us to study shift across different occupational, cultural, and policy contexts. So the project aims to develop nutritional and behavioral strategies for people with high risk of obesity caused by circadian disruption. And that's the point. With this knowledge, we want to develop evidence-based scalable solutions. And in other words, shift work matters because it's an intersection of biology, behavior, work organization, structural issues, and health equity. And this makes it highly relevant target for obesity prevention at a European level. Next slide, please. Thanks. Well, please, this, Marie. Yeah, this slide, thanks a lot. As illustrated in these figures, shift work disrupts the natural alignment between sleep, physical activity, and food intake. And eating often takes place at biologically unfavorable times in shift workers when metabolic regulation is impaired, which substantially contributes to weight gain and metabolic risk. But what is often underestimated is that knowledge alone is not a problem. So shift workers usually know what healthy eating looks like, but evidence shows nevertheless that shift workers exhibit unhealthy dietary patterns, including frequent snacking, high sugar intake, and a preference for sweet, fatty, and spicy foods, which substantially contribute to weight gain. So the challenge lies in access, decision-making under time pressure, circadian disruption, and structural constraints at the workplace, at the site where the shift workers are working. So this is where health literacy becomes a key lever, not as an individual responsibility alone, but as a systemic and multi-level concept. Please, next slide. Next slide. Well, in Shift to Health, we build on the definition of health literacy as the appraise and apply health information in everyday life. So people may have access to information, as I already said, but still struggle to apply it if information is complex, contradictory, poorly timed, or disconnected from their daily routines. So this is particularly relevant for shift workers. Irregular schedules, fatigue, time pressure, and limited food options mean that even good information may not translate into healthy behavior. Next slide. Well, a key message also from the World Health Organization is, and we want to emphasize, is that health literacy is not an individual task alone. So it's a shared responsibility across multiple levels. So this figure illustrates that very clearly at the organizational level. Health literacy means improving structures, processes at the workplace and environments like vending machines or breaks or shift models as well. The second level focuses on professional health literacy. So this means the regular training and capacity building for health professionals, such as occupational health staff, but also managers or healthcare providers. And at the personal level, health literacy relates to people's ability to access accurate information, no fake use, and use it in daily life, also with their families, with their social environments. So finally, assessing health literacy is essential. And it's also essential to measurement health literacy or nutritional health literacy to identify gaps and guide policy development. And this is what we do in our surveys at Shift to Health, to use validated questionnaire to assess nutritional health literacy with surveys. Next slide, please. Well, there is strong and consistent evidence in literature that health literacy is closely linked to overweight and obesity across age groups, and low health literacy is a major risk factor for higher body weight, while higher levels of health literacy are also associated with healthier weight outcomes. And there is a significant correlation between health literacy and BMI in both children and adults. So in children, low health literacy is significantly associated also with higher BMI. And importantly, also parental health literacy plays a key role and is a strong predictor of children's weight status and overall health. So also parental health literacy or the family health literacy plays a major role. Please, next slide. So coming to our target group, there are only a few non-EU studies available with methodological constraints. So first, we see that higher health literacy is consistently associated with health behavior. And this holds true across all workers, regardless of whether they work day shifts or night shifts. So interestingly, health literacy levels do not differ between shift and day workers, or between night shift and day shift workers. Even more importantly, health literacy does not mediate the relationship between shift work and health behavior in these few studies. So this means that poorer health behaviors among shift workers cannot be explained by lower health literacy alone. Rather, the results suggest that the causes of unhealthy behavior lie primarily in structural working conditions. So these findings are very interesting for us, but we are very curious what our data from the EU-wide survey would say, because most of these surveys regarding shift workers are non-EU studies. Please, next slide. So building on the concept of health literacy, there are two relevant dimensions for us, the nutritional health literacy and the food literacy. And there are some specifications, because nutritional health literacy refers to the ability to find, understand, evaluate, and use nutrition information in order to make healthier choices. And it's not about individual skills, as I mentioned before. It also depends on the availability, accessibility, and quality of nutrition, information, and services. On the other hand, food literacy focuses more strongly on practical and everyday competences. It includes, for example, food planning, preparation, decision-making, in other words, the ability to translate knowledge into action. And this model on the right side explains food literacy very well, from planning, managing, selecting, preparing, and finally, eating the food in a health-promoting way. Next slide, please. So also studies revealed that food and nutrition literacy have significant impact on nutritional quality. A high level of competence in these areas are directly linked to positive effects of a healthy diet, but nutrition literacy not alone affects body weight. Yeah, it's also associated with but is also associated with a lower risk of cardiovascular diseases, more favorable body measurements, body fat mass, improved blood lipid levels, and more effective blood pressure management. Next slide, please. So how do we move from all this evidence on health literacy, nutrition, and shift work into concrete action? So the iceberg image illustrates this idea quite well. The integration hub, we call it that, it's work package 6 and 7 in Shift to Health, brings together evidence from the scientific literature and findings from all Shift to Health work packages. So we have work package 1 focusing on lifestyle factors relating to the development of obesity in shift workers compared to non-shift workers. We did an online survey across Europe, focus group discussions and interviews with management and shift workers for needs and expectations, and a cross-sectional study in 5 different EU countries. So this evidence comes also to the integration hub to develop recommendations. Work package 2 was all about preclinical pre-obesity biomarkers and biological pathways. We also developed, test, and evaluate a complex intervention aiming by behavioral changes of shift workers and to evaluate this. And we also do in vitro intervention, product development, and with this product, a food intervention study. So while those work packages generate evidence, our integration hub integrates these findings and translates them into recommendations. So with this strategy, evidence from chrononutrition and behavioral research is transformed into literacy-sensitive, multi-level strategies with a measurable public health impact. Next slide, please. So to ensure that our recommendations are not only evidence-based, but also usable and scalable, we have concrete implementation tool. A key instrument here is the health impact assessment to evaluate recommendations we give and the obesity prevention strategies which come out from the evidence on system levels. So the HIA allows us to systematically evaluate those on a system level, looking not only for potential health benefits, but also at feasibility, unintended effects, and equity implications. So based on this assessment, we translate them into tools like an e-handbook adaptable for different target groups, employees, professionals, policymakers. We will set up training programs and integrate them into curricula for professionals from local trainings to European use. And we set up digital applications like apps or websites that support everyday decision-making in shift work contexts, which is easy to distribute, updated, and adapted also linguistically. So what is crucial is that all these tools follow a multi-level approach, and they should be designed to support individual behavior, but also to inform organizational practices and policy-level decisions with the aim to reduce health inequalities. Next slide, please. So my takeaway or our takeaway messages are shift work creates structural barriers and increase obesity risks. Obesity prevention must move beyond individual blame. The impact of low literacy is that it increases the risk of obesity, and that nutritional literacy and food literacy is essential for understanding nutrition information, making healthy choices. So Shift to Health, put evidence together, do it in scalable tools, focusing on a multi-level approach. Thanks for your attention, and happy to answer your questions.
Thank you, Bianca, for sharing your very interesting data. And we look forward to your evidence-based recommendations and also scalable tools. I think it will be very interesting. So we move to the next presentation, and then if we have questions, we will forward you the questions. Thank you, Bianca. Now we move to the next presentation by Mr. Umberto Restelli, representing BioStreams project on health economics estimator tool for obesity prevention programs.
Good afternoon, and thank you for the presentation. So I will start with my part of the presentation. I'm Umberto Restelli. I'm a health economist, and I direct an observatory on value-based healthcare at Duke University, and I collaborate with GRAS, which is a partner of the BioStreams project. Okay, just briefly presenting the objective of the BioStream project, which is to support the optimal use of healthcare data to generate metadata and new knowledge, methodologies, and tools for creating and deploying scientific platform for research in childhood, overweight, and obesity, and better diagnostic and therapeutic approaches. Within the BioStream project, we actually implemented a cost estimator tool, which is aided at supporting policymaker in estimating economic impact of implementing childhood obesity and overweight prevention or management programs. From a methodological point of view, what we have done, we have conducted a systematic literature review to identify cost components related to childhood overweight and obesity, a narrative review to identify already published health economic cost effectiveness and cost utility models that were used to estimate childhood obesity and overweight prevention programs by either HTA agencies or national institutions. And then we have worked on a workflow service design guided by the streamline activity diagram to map and to understand the complex processes involved, considering both roles and responsibilities. The model that we have then built is a two-stage cost utility model, which resembled the one that was used by the UK National Institute for Health Research to conduct similar activities. And in the first stage aimed to predict adult weight status as a function of childhood weight status up to 29 years of age. And the second stage is basically a Markov model with yearly cycles in which subjects can go through the health states that you can see here. So the first one is characterized by the weight status of the person. And then the subject might or might not develop comorbidities such as coronary heart disease, type 2 diabetes mellitus, colorectal cancer, or a stroke. And of course, then in the model, there is the death health state, and the transition probabilities are calculated both from the comorbidity status and the age of the subject within the model. All the transition probabilities data were taken from literature. So basically, the cost estimator tool report the information that you can see here. So the user can select any European country and any EU actually country. Then it is needed to indicate the target population in terms of number of subjects in the target population, the mean age of the subject within the target population, and the distribution of the subject among different weights. Then the user should also indicate the intervention parameters. So the user can select the type of intervention that can be either nutritional, physical, or mixed. The source of effectiveness data that can be either manual input. So if the user already have in mind their target effectiveness of the project, they can write what they expect the project to produce, or they can select the results from BioStream's activities and programs. Of course, from this point of view, we are still the project is still ongoing, so we don't have right now the results of the school programs that have been implemented. Another aspect could be to use data derived from literature, but the problem here is that there is a wide heterogeneity of results published in literature. So for the same type of intervention, we might have very promising and effective program and programs that basically did not have any effectiveness. So from this point of view, we are still evaluating how to incorporate also literature data within the model. And then the user should also add the effectiveness projections if they rely on their own estimates at 1 and 2 years. Then an economic data and parameters screen will show up, in which the user should select the economic data source. Also here, they can decide to add data by their own or to use data from the BioStream program. Indicate any discount rate, and we didn't want to suggest any discount rate because it depends a lot on the recommendation that guidelines recommend at national level. And the program design costs should be estimated, and the program delivery costs in terms of staff, facilities, equipment, and supplies should be reported. Also here, we can also add data from literature, but since each program is very specific, the user probably at this stage already have estimated which are the likely program delivery and program design costs. And at the end, what the model will show you is the differential costs between the do nothing scenario and the implementation of the program scenario, either in the short and in the long term, the differential quality adjusted life years that are expected from the do nothing scenario and the program implementation scenario, the pathology cases prevented, and the cost utility ratio. So how much has costed to increase of 1 year of one QALY the life expectancy of each subject. So basically the workflow consists of a dashboard with user interface for visualizing both data and results, which is built as a standardized CDISC-based data model that integrates continuously updated clinical and economic data produced through BioStream's pilot studies to support comprehensive analysis. So as I said, we expect to add the results of the pilot studies within the model, but of course, data are still ongoing and we are still analyzing those. So in conclusion, this is an example of translation of economic evidence into practical decision support tool tailored to the needs of health managers and policymakers. We developed a user-oriented simulation model because the final objective is to support transparent prioritization of intervention and efficient resource allocation. And the approach that we use is consistent with WHO guidance, ECO framework, and the acceleration plan to stop obesity, which stress the use of integrated data system and decision support tool for evidence-based action. So before ending my presentation, since our objective is also to connect with either policymaker or other stakeholders that are interested in participating to a dedicated workshop to fine-tune the model and the tool that we have implemented. We would be very happy if any of you is interested in supporting us in fine-tuning the model and the tool, to write to the email that you see in this slide of Dr. Matteo Colombo, which is a partner of IT GRAS. Because for us is crucial to have input from your side to be sure that the tool and the model really respond to your needs. And another element that I would like to stress is the fact that although the model was originally developed for children and adolescents, it can of course be adapted to adult population. So to broaden the impact of obesity prevention policies and the range of citizens who can benefit from the use of this tool. So thank you for your attention.
Thanks to you, Mr. Restelli. I think you had a very nice presentation. And as we are in a digital era, the tool you will develop or you have already developed will assist for prevention of obesity, not only in the adults, but also for the children. Now we can move to the presentation of Professor Rocco Barazzoni on Policy Spotlight, Italy's new obesity law, implications for research and systems.
So good morning, everybody, or good day. I am Rocco Barazzoni from Trieste, Italy. I am very grateful for the invitation and the opportunity to talk with you about this well, maybe groundbreaking, I would say, or very important initiative that coming from my country, Italy, with a new obesity law that has been extremely encouraging for the network of stakeholders that are trying to address this very difficult challenge. And I will speak about this new law. I'm going to apologize first for not being able to be with you live today. I had to record this video, but I am grateful for the opportunity and the flexibility to accept this approach as well. So these are my disclosures. And very quickly. So from the previous speakers, I think there is really no need for me to spend time discussing why obesity is and should be considered as a chronic disease, a very important and severe chronic disease, which shortens basically life expectancy of patients affected. There are important alterations of regulatory mechanisms regarding food intake, body weight, energy expenditure, and the adipose tissue becomes a sick tissue, leading to a number of severe complications. So obesity, we believe, I hope we all today believe in this panel that obesity is a disease. It's been recognized, of course, and declared as a disease by a number of stakeholders that are mostly scientific society. Also, the World Health Organization has recognized obesity as a disease, but there is still a lot to do in terms of healthcare systems and also general perception. We know that the European Commission has issued this kind of a statement or recognition that obesity is a chronic relapsing disease with a number of complications. So there is already some political recognition. But in fact, the journey from scientific awareness and evidence that there is a disease to the, let's say, actual effective implementation of healthcare to effectively and successfully address this disease is quite long. And I think that if we consider these steps, education for healthcare professionals, awareness, including also the general public and the policymakers, leading to policy and implementation, the journey is very long. So in case of obesity, I think we are still not there. We are the awareness of a disease, but people that are actually diagnosed with obesity and people that are actually receiving evidence-based anti-obesity treatment are a real minority of the huge number of people living with obesity. And that's of course a big problem. One of the main consequences, for instance, is that obesity is still considered, let's say, a choice, a sort of an individual responsibility, where people more or less being lazy and lacking of will to change their habits, their behavior, their lifestyle, are considered to be fully responsible for their condition. And so they are stigmatized, they are considered weak persons, they are kind of, let's say, excluded in a way. And all this brings to vicious cycle where people tend to ignore the disease, not to seek help, not to seek treatment, and they actually undergo vicious cycles of increasing food intake, stress responses, and so on, which only make the problem worse. What I'm going to tell you, however, today is something a bit more optimistic, and specifically the experience that we had in Italy, where, again, I'm not saying we took a kind of shortcut in this journey towards effective healthcare implementation, but in fact, maybe we were lucky, or maybe we were proactive. There were several stakeholders that started networking towards building an effective policy and an official policy recognizing the problem of the, let's say, new disease, that obesity being recognized as a disease. So this networking has been effective in maybe shortening the path towards legal and official recognition. Since 2019, there is this parliamentary group on obesity and diabetes that was created. The Member of Parliament Roberto Pella has been the president. There was from the start a scientific connection, you can see at the bottom, with some bodies and foundations and many stakeholders, again, discussing with these, I would say, enlightened politicians that were willing to listen and act on this problem. The networking also included the Italian Obesity Society, where I was the chairman until a few months ago, until October, patient organization, Amici Obesi, advocacy foundation. There was always some support. Of course, I would say that's more or less not only inevitable, but also useful to have company support and lobbying for this kind of activity, of course, in full transparency. And this networking was able enough and successful enough, although it took several years, to come to this final result, very important result of an Italian law, and with the Italian Parliament being the first to recognize obesity as a chronic relapsing disease. This is a kind of a celebratory paper that came in Nature Medicine a few weeks ago, and the law was approved about 3 months ago, in the beginning of October. The picture you can see on the right is actually myself with Member of Parliament Roberto Pella. He came to our Congress in Trieste on October 2nd, and the law had been just approved a couple of days ago, so we were able to actually celebrate. There was a lot of excitement and even emotion during the event. I think we were lucky to have this kind of timing. So I'm going to tell you a little bit about the content of the law. The first article actually defines very simply obesity as a disease. So it's not only no longer, I would say, a precursor or a condition or a situation coming from, well, we don't know where, but basically from individual responsibility, as we said before, but a true disease with priority for clinical intervention and public health strategies. And in Italy, we have this system where you need to have also the network of regions that have, each of the 20 Italian regions have their own healthcare budget and healthcare, let's say, independence in the healthcare organization. So it's very important that the regional system also embraces this approach and obesity be formally included in the list of chronic diseases that leads to the definition of these essential levels of care, ELC, that are necessary to define what exams, what treatment, what actions are to be guaranteed by the Italian National Health Service, which brings actually the disease to the full implementation. And it's advocated in the law. It's not, let's say, happening overnight, but it's important that the practical approach is also defined. The law advocates, also promotes, encourages a multidisciplinary framework. It also has, of course, an eye on prevention, but also mentions and declares that there is a need for a budgeting also for training of healthcare professionals for effective approaches. So I think it's a very comprehensive approach, which is potentially quite effective if it were to become actually implemented in the healthcare system. And the Ministry of Health, which is also encouraging, has decided to introduce, to create an observatory where experts will be appointed to monitor the progress from this, let's say, official legislation and declaration that it needs to be done to the actual actions that will need to be implemented. And then again, this is in a nutshell, the main contents of the law, which, if you think about it, it's not so groundbreaking in principle, but the fact that it is written in a law, in an official document coming from the Italian parliament, really is what makes this document unique and somehow makes us kind of proud, at least, to be able to lead this kind of initiatives that happens in Italy for the first time at a global level. So this is something I would say, advanced in this field. Of course, the next question is, can we treat obesity by law? I think that we are all aware that every law, not only this one, needs effort for actual implementation. And we need to be aware that there is still a long way to go. I wouldn't say that this is just the beginning of the journey. We already have a few steps, but we really need a lot of additional attention and effort and energy to really bring this one down to the ground, to the everyday routine. But I have to say that there are already some very encouraging signs. I mentioned before that this principle actually needs to be embraced by the regional systems and introduced in the chronic disease plan for the national healthcare systems with the regional basis. Well, that actually happened 3 weeks after the law was approved. That's, of course, no coincidence. Of course, the timing was particularly lucky. But let's say that was a parallel track that, however, benefited, I think, from the momentum and the noise that was created around the law. So only a few weeks after the law, this declaration, this acceptance of obesity in the chronic disease plan and the chronic disease list, which is the first step for actual implementation of the essential levels of assistance or care that we talked about before. I think that's very encouraging. And I hope that 2026 will be the year or the time when these levels of assistance, these efforts, these let's say, examinations, diagnostic procedures, these treatment also procedures that need to be guaranteed under our national healthcare system will be finally defined. And then there will be the opportunity to implement them, let's say, by law, or at least they will become kind of mandatory, at least on paper. So that's another very encouraging step that I think was not by coincidence associated with the approval of the law. Of course, we need money. I think there is I was told that it's a technicality. There was a need to associate a budget to this law that is quite new, and the budget law was being already defined since several weeks or months. So the initial funding is really, I would say, extremely small if we think about the challenge ahead. 3 million euro was associated to the law. But of course, this is just the start, and I would say a technical hook to connect the law to some budget to start working. But I think that it will be necessary to have substantial increments. And of course, the advocacy on that is starting. When we define the essential levels of assistance, I think we will be able to also come up with budgets and requests that I think will be important to discuss again with the policymakers. I think another important aspect, however, is that the law should and is already, I think, becoming a tool to improve awareness and also education about healthcare professionals, patients, the public at large. There has been a lot of noise about this. I showed you the ceremony at our Congress. There was, let's say, media coverage, social media coverage. Of course, the heat is already starting to decline. We need to continue pushing and discussing, but I think it's already showing that there is a good perception and a good pickup of the message from the general public. We hope that really it will be possible with this awareness that obesity is a disease, increasing awareness that obesity is a disease, to reduce, ideally to stop the stigmatization of the patients. And I would say also the stigmatization of the treatment, because if you believe that obesity is not a disease, it's just a result of individual choices, wrong choices, and individual responsibility, then the treatment becomes eat less, move more, just a sort of a paternalistic approach, and that the patients and also the healthcare professionals, the treatment, do not really deserve the funding for serious and effective treatment. I think we are all aware that the elephant in the room is the new opportunities to treat obesity with pharmacological treatment that is really opening up unthinkable and unimaginable potentials for successful treatment. Of course, it needs to be chronic treatment. That's another issue, but we need to discuss about the duration of treatment after we have started to really accept that we have pharmacological effective options. And that's something that will also hopefully be more and more accepted by the medical community, by the patients, that again, being a disease, we can have different approaches. Of course, lifestyle change will remain the foundation of the treatment. Bariatric surgery will remain for the, let's say, more severe obesity cases, but we will have also other options. And we hope that really a serious medical discussion will be also made possible or facilitated by this law. Of course, the science is not finished. We need the clinical research to have the optimization of the treatments in the context of a new disease. So we need more clinical research and more basic research. Again, the hope is that this law will really allow for more awareness on the need of funding for more research. Research is not over yet. We need to find the more effective treatments, of course, but also more mechanisms, the more targets for pharmacological, but also for other kinds of treatment that might really increase the options, reduce maybe the costs in the future for managing and treating obesity and its complications. And again, the journey, like I said, is just begun. But I hope that with this short presentation, I was able to really give you a glimpse of the excitement that there is in Italy, and hopefully around Europe. The experience has been shared, of course, through the European Association for Obesity. Italian society is part of that. There is a lot of buzz and discussion, and hopefully there will be the opportunity to use this initial step as an example, or as a, let's say, a template for other initiatives that may need to be tailored to the healthcare systems and to the needs for each country. But I think, again, political and policy recognition is really a breakthrough, and we hope that this will help everyone to address these serious disease and ultimately to improve the life of our patient, which is the first priority. So thank you very much again for the invitation and for your attention, and I wish you a good discussion for this webinar. Thank you very much.
We thank Professor Barazzoni, and also we have to congratulate Italy being the first in this area, in this field of obesity, having the law. I would like to have a question to Mr. Restelli. Could it be possible to expand your tool across all the European countries or the members of the EU and all the countries all around the world? Because I think Italy was the leading force for having a law. How would you comment on that, Mr. Restelli, together with your tool?
Yeah, thank you for the question. It would be very interesting also to include any country worldwide. The point here is that the model consider costs and other parameters that are related to the EU countries. We performed a specific literature review to include this type of cost elements. If we expand it worldwide, then a literature review shall be conducted for each country that are included. And furthermore, this review should be updated every, let's say, 2 or 3 years to be sure that it is updated. So from a technical point of view, it can be done without any problem. The only problem I see, but it can be solved, is related with the effort of conducting a literature review related to each of the countries that we will include. But as I say, it can be done from a technical point of view without problem.
Thank you, Mr. Restelli. Now, we have one question regarding the genetic loci. With the genetic loci identified that link with obesity, what information do the genes identified give us about the mechanisms involved and how much influence do these loci have? I think I can direct this question to Professor Eriksson. Jan, if you are still together with us.
Yes, I would say in general, it's genetic loci that are related to hypothalamic function, like the FTO gene, but it could also be other unknown mechanisms. So if you do an unbiased approach with GRAS and so on, you find all kinds of genetic variants, which actually we don't know what is the mechanism, but most of them that are mapped out, they relate to appetite and food intake.
Fernando, would you like to make any comment? No? Fernando, do you have any comment?
Yeah, actually, I agree. So we are trying to analyze the GWAS analysis and data from worldwide, but actually we are focusing more at the moment in mental disorders, not much in obesity, and only what we were able to find, as we have mentioned, was negative genetic correlations between extreme weight conditions, in that case, obesity and anorexia. Many years ago, so a lot of groups were analyzing also melanocortin factors, genetic factors in Germany, but also many other groups, but we are not so far, I think so.
Thank you. And, now, before concluding, I would like to thank to all the speakers because they had been very excellent presentations and with the very distinguished speakers. And I think obesity is a growing health problem, not only in the developed world, but also in the developing world. And early prevention of obesity is crucial for preventing all the health consequences such as diabetes, hypertension, cardiovascular problems, renal diseases. So I think we have to emphasize early prevention and reinforce diet, not only diet, but also lifestyle modifications. And finally, which is becoming much more evident in nowadays, the screen abuse all around the world. We have to prevent screen abuse not only in the adults but also in children and adolescents. So I would like to conclude by thanking to all the speakers, to all the organizers, and just to remind, I would like to remind you that the 4th of March 2026 is the World Obesity Day, and on behalf of APROBES, we are going to organize a workshop in Cordoba. So the 4th of March, obesity, you are very welcome to the workshop on obesity also. Once again, our sincere thanks to all the participants and also to the speakers, to the organizers. Thank you.